Hello, good evening. Welcome to Kubatana meeting with Dr. Mukonoweshuro. He is joining us from Zimbabwe. He is a resident physician in Zimbabwe and is also CEO of Ultramed Healthcare. He's joined us before on one occasion, and we're thankful that he was happy to come back and talk to us again today. So, how are you, Dr. Mukonoweshuro? Can you hear me, Dr. Mukonoweshuro?
Yes.
Sorry, I think we're losing you a bit. Can you hear me?
Can you hear me now?
Okay.
I can hear you.
Okay. Yeah, we lost you a bit. I think the network is a bit poor. And we've lost the video now. You're back. Welcome back. We might need to just do an audio, I think. Okay, like I said, Dr. Mukonoweshuro has been with us. Last time we were talking about COVID. So I don't know if you'd like to just shed light on just briefly what's happened so far. Is it as you expected? Because you were saying that you're going into a different phase now and you're relaxing the lockdown.
Yes. Yes. So about maybe 60% of the economy is back up again, but under very strict sort of protocols. Our numbers are still quite low. I think in total we have 48 patients who tested positive.
Okay.
Of the 48, I think only 4 have deceased, and 18 have recovered, and the rest are still active. But the protocols are still very strict. Social distancing, movement limited only to essential movement. So I think so far it looks like we're doing okay.
Oh, that's very good. It's very good to hear. So today, Dr. Mukonoweshuro, we just asked you if you could tell us, shed light to our primary health care, what it is like in Zimbabwe, how we're doing in terms of primary health care.
Yes, it's an interesting question because I think where we are can improve as far as access to primary healthcare services is concerned. As you know, we used to have a very strong primary healthcare policy back in the day. And of course, there's been a bit of slowing down in that front. So I think there's still a lot that needs to be done to revamp that and to increase access to the greater part of the population, because the bulk of our population still struggles to access doctors even at primary healthcare level.
Okay, so primary healthcare, they say it's concerned with health promotion, disease prevention, and management of disease when it occurs. So which part are we really lagging behind?
Okay, so the prevention bit is one arm, and I think on that arm I think we're still doing quite okay. There's lots of information dissemination through radios and now social media, but the concept is not complete without talking about the general practitioner, who is still part of primary healthcare. The general practitioner or the family practitioner, or clinics. So if you would remember, growing up in Zimbabwe, there's lots of city council clinics, which were highly functional. And it's those things we're saying we need to revamp that entire system from the city council clinics to the general practitioner. And we need to work out a way to increase the access to that level of care. Right now, the average consultation at a general practitioner, for example, is about $20 US. And that is actually way out of the reach of most people. So what then happens is, people will start to feel pain today, and they will sit on that pain for 5 years. They will take this and that and take this and that. And eventually, by the time they go to see the doctor, it's actually a cancer that has grown. So what we're trying to advocate for is seeing a doctor must be, especially seeing a general practitioner, must become democratized. It must become as basic as buying a loaf of bread. You should be able to see your doctor whenever you feel the slightest pain. So the cost, which is really the biggest barrier to entry, needs to come down somehow, without prejudicing, obviously, the doctor, because it costs what it costs. Likewise, you can think about dentistry, for example. Your average person in Zimbabwe will turn 40 without ever having gone to the dentist. By the time they go to the dentist, they have 5 rotten teeth and 3 others which need work done on it, and it's so expensive. So what we're saying is, how do we make seeing a dentist easy so that people can see the dentist every 6 months? That is the conversation that needs to be had.
So last time when you were with us, we talked a bit about telemedicine. And as far as I understand, before COVID began, some people were having reservation about telemedicine. But with COVID now, I think there's been a push as to looking at it more closely as to seeing the benefits of telemedicine. Would you like to just explain to us, how far we are in Zimbabwe with telemedicine?
As far as that is concerned. Yeah, in fact, what I will say is telemedicine has been happening all along, but just not at a formalized level. Because if I meet someone at the bus terminus and they get my number and they know I'm a doctor, the next time they feel something in their body, they're going to call me. Doc, listen, this is what I'm feeling. And I tell them what they need to do. So telemedicine has been part of the health system for a very long time. So people just, sort of resist the idea, but the thing has been there already. So it's now just a question of institutionalizing it and formalizing it and saying, okay, this is now a well-recognizable mode of getting consultation. And that's the next step we need to get to. But everyone now, I'm sure, is because of COVID-19, will probably find it easier to accept the concept of telemedicine because of the risk of actually coming to the surgery. So you can come in with a completely unrelated issue, maybe hypertension, but you're putting yourself at risk because the last patient I had might have actually been a COVID-19 patient. So you actually don't want to be coming into the clinic unnecessarily.
Okay. So I've seen that with telemedicine, do you need an app of some sort, or is it, for now, is it just like telephone consultation, talking to your doctor over the phone? Or do you need some form of software?
Look, it would be nice to build a platform, and that's what we're sort of trying to work around to say, how can we build a centralized platform where if anyone who needs to talk to a doctor can actually go to that platform, which is a billing module, because you've got to find a way to pay the doctors as well. But otherwise, people right now they call, they do WhatsApp, and there's been a couple of apps that are being floated around. But see, the problem with apps is the cost of data. The cost of data here is quite high. So most people don't actually have access to Wi-Fi. And so apps don't really have a lot of traction, but WhatsApp, definitely, phone calls, definitely. But building a platform is actually the way to go.
When you're talking of building a platform, are we talking of something that's so that one patient, if you see a doctor, and you see a different doctor, is the information is shared, or what sort of platform are you talking about?
Yeah, so it has to be, obviously an IT platform. I'm trying to run away from the app.
Okay.
You know, it has to obviously be an app of some sort. But we wanted to have the sort of cost efficiencies that WhatsApp has, for example. If you're going to make a WhatsApp phone call, voice over internet calls are much cheaper than your standard voice GSM call. So we want to find a way, for people to call without having to, endure the sort of expenses involved with either using data or using voice calls. But for now, it's what we'll have to do. We have no choice for now until some IT person comes up with some clever idea. We're trying to engage a couple of developers to say, I don't want just your standard app. How can you if you're going to do an app, how can you make this thing cheaper so that I can do a 15-minute phone call without the phone cutting with my patient, and preferably, a video phone call, so I can actually see what they're telling me and they can actually show me where it hurts and things like that.
So that would be quite a major breakthrough in terms of the primary health care we're talking about. Because even with the early detection, you're saying if they can access somebody, a health professional, sooner than later, then it means the disease progression won't be that much before they are attended to. Can you tell us a little bit about health promotion and what we're doing in terms of health promotion? I know here we have like breast screening awareness, we have cervical cancer or prostate, all those things. Are they in Zimbabwe at the moment?
Yes, we do a lot of that. As you might know or might not know, the First Lady champions the CA cervix screening. So she's been very vocal around screening of cancer of the cervix. And in places like Zimbabwe and other resource sort of poor countries, we use what we call VIAC, which is visual inspection of the cervix, with the use of acetic acid. Acetic acid is essentially vinegar. So VIAC was developed for places like ours. It's a cheap test to run, but very useful. So because cancer cells in the cervix react to vinegar and they can show themselves. So we do a lot of cancer of the cervix screening, but we're still not doing it enough. In my mind, I think currently we've got maybe 6 or 7 VIAC sort of clinics, maybe a bit more, but we need to increase those numbers. We need literally thousands of these units all over the country so that every year or every 2 years, women can actually go in and get screened. I mean, there's nothing as heartbreaking as seeing a 33-year-old from Highfields coming in with stage 4 cancer of the cervix. Like, where were you? Because the cancer doesn't happen in 2 weeks. It happens over years. And that's what makes you realize that people don't quite have access as they should more. We need to increase the screening centers. There's a lot of education that goes around advocacy on radio, but we can always do more.
Yeah, I realized $20 to go for to consult a doctor doesn't come easily in Zimbabwe. Like you say, that's where the pain is. Just to access that money for primary health care. Can you tell us a little bit more about other healthcare promotions that are going on in Zimbabwe at the moment?
Okay, so our healthcare has a lot of NGOs. So the biggest, like Global Fund, I think their main sort of center of interest is HIV, TB, and malaria. So there's a lot of work and a lot of money that's gone into HIV, TB, and malaria. And even I think our rate of ARV coverage is quite high. I think we're now at about 78% of people who need ARVs who are actually on ARVs. So there's a lot of work going on there. As you know, obviously, things like HIV have taken the limelight for quite a number of years. Then, of course, there's things like cholera, which then happen now and again. There's obviously lots of information going around to sort of educate people on typhoid and cholera. I think from the health education point of view, there's a lot of that happening. But there's a lot of programs we used to have, such as your village health worker concept. And that's sort of that's a concept that needs to come back up again, because it used to be quite strong. Right? No, did I get that right?
Yes, true.
Yeah, the village health worker who would go around in community. So you educate, and it's also employment creation. You get, ladies who are trained in some of these things, they go into their communities, they educate, peer to peer. And I think that's an exciting project that needs to be revamped again. I think it had sort of gone down because of the other, challenges in the economy. But so those are some of those things we need to do. But there's a lot of advocacy going around. We can do more. Then, of course, there are certain conditions that are not talked about as much, such as your psychiatric illness. Generally, psychiatric illness has maintained a pariah status within our community. So a lot of senile dementias in the homes are just tied to trees or just locked up in the home, not allowed to go out. And there's not enough conversation going on around some of these topics. TV as well has some health programs that are running right round, and I think that helps as well.
I've seen you on several radio programs, like the Wednesday one. Yes, is that part of your?
Yes. So some of that.
Mm-hmm.
No,
Would
definitely.
you like to just talk about it?
Mm-hmm. Yeah, so definitely, I've been doing a lot of radio. I think I've done almost all stations, and okay. I've done TV as well. It's really, corporate social responsibility. Information is power. In fact, information can really be the difference between life and death. If I tell you that, a lot of deaths from diarrhea, especially in children, can be avoided by just giving the child salt and sugar solution. Like, no child has to die from diarrhea, but we have hundreds of children dying from diarrheal diseases because the mother simply just didn't give salt and sugar solution in time. And sometimes, and this is what drives me to go on radio to say, if perhaps someone can just catch that one piece of information, it can actually save lives. So that's the sort of information we need to drive even harder in the community, so that, people are aware of some of the interventions that can actually save life before they actually need to go to the clinic or see the doctor.
Yes, thank you very much for that, because part of it, once patients are no longer just beneficiaries, once they take control of their health, it's a lot easier. Any form of intervention will be more effective if everyone participates in this health promotion, if everybody takes ownership of their own health. So thank you very much for all that education. So you talked about Mbuya Nyamukuta. Is that something that's going to come up, or how do we get it to come back?
Yeah, you see, this is why we are talking. This is why we are in conversation. Because I don't know who we are waiting for, because I suspect that we are the ones that we're waiting for. So I think this is something that a group like ours just needs to sit down and say, what is the current status of that program? And what can we do? And it's not actually very expensive. And, it actually gives occupation and jobs to a lot of people sitting in the community. You bring them in, especially, ladies, women, bring them in, educate them, and then send them out into, there's a couple of pockets of that program happening around the country, obviously paid by different NGOs and things of that nature. But I think that the program can actually be made a national one. And that's, I think, a project we need to sort of put a highlighter there and look at it later and say, what can we actually do about it?
That's a lot of food for thought. You've talked about telemedicine, and I can see how this Mbuya Nyamukuta could benefit from having a doctor at the end of the phone, for anything that's complicated, as well as when we look at management of the disease when it occurs, you are CEO of a medical aid company. Can you tell us how that could benefit people if they can at least save the basic medical aid, at their disposal?
So the beauty of medical aid is that it answers the financing question. So you can build hospitals, you can equip those hospitals, but how do they pay for that service? And most people actually don't actually have the sort of money to pay. But how medical aid works is you get, people pool resources. So I've got $10, you've got $10. My $10 is not enough to get me treated. But if the 10 of us are putting $100 into the pot every month and we don't fall sick on the same month, sometimes we can go for 8 months without falling sick. We build a reserve that allows for the day I fall sick to actually access care. So what we have tried to do is to have a medical aid fund whose premiums are priced in such a way that people can actually afford. So you can't charge 5,000 RTGS to a vendor on the street. It shows a complete disconnection from what people are actually able to afford. So let's work with what they can afford. And then we work it backwards to the doctor and say, this is what our people can afford. This is the money in the basket. May you please see them. Can we work out a consultation fee based on what we have collected? That is a solution that I feel is Ubuntu, is Wunu, has a sort of philosophy that has driven our communities. You can't charge what's not there. And as a result, what is happening is that doctors spend the day in the practice without seeing any patients. Because yes, they have rightly priced their products. They want $20 for a consultation, but if no one can afford it, you're going to sit there the whole day. But if people could afford, say, $5 consultation, and you see 10 patients a day, now you're going home with $50 per day. So that's the sort of thinking around, the economies of scale, around numbers. Let's have low margins, but let's drive numbers. Let's get the bulk of our people in. As you know, Zimbabwe only has about 1.4 million people on medical aid out of 17 million people. So there's a good 15 million people who are completely exposed. So we need to bring them into some kind of fund, which can then take care of them when they need to.
Thank you. Just on the chat here, somebody, Nancy says she's actually very proud of the Mbuya Nyamkuta program back in the 60s because it brought her into the world. So yes, we do need that.
Oh, wow. That is
if anyone
amazing.
has got, any questions for Dr. Mukonoweshuro, please put it in the chat and we'll just read it to him. Yeah, so that actually encompasses the health promotion, the disease prevention, as well as the management. So if all those three, the telemedicine, the Mbuya Nyamkutas, the medical aids, all those working together will have a better healthcare system in Zimbabwe. Is there anything else you'd like just to talk to us about the health promotion in Zimbabwe? Or the early detection? What are the statistics?
On that, I just wanted to just throw in a bit of a controversial point there. Our biggest stumbling block at the moment is actually the religious organizations, particularly your Pentecostal churches with prophets. There's a lot of misinformation that's happening there. I remember going to one of these churches one day and seeing, a long queue of, patients with cataracts. A cataract can be operated in a matter of minutes. It doesn't need anointing oil and doesn't need all these things. We've got a backlog, obviously, in operation of cataracts in the country. Last number I heard was 70,000 was the backlog. So that's why you find, like the programs that people like Dr. Guramatunu used to run, Eyes for Africa, where you would go to a place, Gokwe, and then run, a cataract clinic. Those are some of the interventions that can easily be funded and make a world
think we've lost Dr. Mukonoweshuro now. So we'll just wait for him to come back. Yeah, he's talking of cultural barriers as well as, I don't know, this is what, religious barriers. And I think it will all, it will all be solved by the health promotion. When individuals take their health, they own it, not put it in the hands of a pastor or some religious healer or something. So it's all to do with education. Are you there, Dr. Mukonoweshuro? We have lost him. Anyway, that's very informative. Anyone else has a question? We can always email him, and he can respond on our Facebook. We'd like to thank you all for coming, and I think it's been a very informative evening.
Thank you.
It's been a very informative evening. So let me just mute this person. So we've talked of telemedicine and the benefits of it, and together with the health advisors who used to be in the clinics, most of them, I think they, retired. So we just need a new batch of health advisors being trained. And with telemedicine, having doctors at the end of the line, that would really help our people to access healthcare early. So, and with promotions like cervical screening and breast screening as well, that would really, really help. Is there anyone else with any questions? I think the rest of whatever Dr. Mukonoweshuro had to say, we will hear it on Facebook. If nothing else, just a reminder that Kubatana is a non-profit, non-political organization, and we want to serve the poor in the society, the disadvantaged in the society. We thank you all for your contribution so far. As you have seen, we managed to do quite a lot, helping people have food parcels. But I think now that the lockdown is going to be relaxed, we're going to go back to our original vision, which is to look at healthcare. That's why we had Dr. Mukonoweshuro just come and educate us on what primary healthcare can do to benefit the Zimbabwean population. And the idea of medical aid as well is really good, because nobody has got thousands stashed under their bed for the time when they are not well. So medical aid, we will call him again, I think, for him to just explain all his packages. If you go on internet, it's called Ultramed Healthcare. You can see a number of packages that are available, and they are available for your immediate family. They are available for your distant family. As you know, as Zimbabweans, you don't get to say avandimbuya vasekuru vangu, mbuya ndimbuya, and if they get sick, you still responsible for them. So it might be a good idea to just get them on medical aid as well. So Dr. Mukonoweshuro, any last words now that you're back? Any last words, Dr. Mukonoweshuro?
Yes. I really think that what we have started here can actually grow to be something very, very big. I think there's no one who is coming to save us. We need to save ourselves. The Zimbabweans that are in the diaspora obviously have the opportunity to see how a system works. a system that actually works. And I think that it's a good thing to bring those ideas home. So all these ideas, they can be driven by us. No one else is coming to drive them. Places like China have, they built their own systems by themselves. And I think that we've got the knowledge, we've got the expertise to actually do that. So I think let's keep going and not get discouraged or tired. It's going to grow and one day become like the Red Cross International.
Thank you so much. Thank you for the time and, for that education, because sometimes we think we know, but it's good when everything is put in the Zimbabwean perspective so that we don't imagine things which are way out, but we put everything in the Zimbabwean context. And we know what it is, or we know what it is like in Zimbabwe, our relations with our people. We know the barriers, like you were talking about, the religious barriers and their cultural barriers. So like you say, it's up to us to carry the torch and make sure that we rise up and our people get the health care that we need, that we can afford them as well, because it all needs us working together. And like our name says, it says Kubatana, which means, we are in this together. So with you on our side, everybody, I think together we can. So keep supporting us, keep contributing, keep suggesting. Any suggestions are welcome. Thank you for joining us on Zoom. There'll be many more Zoom meetings. There'll be more educational meetings. Whatever we learn, we need to just take it back to our families, to our friends, educate them on the importance of early detection and primary health care. It's best to spend that $20 rather than to cough up $20,000 when a disease is progressed. So thank you so much and keep donating. See you next time.